Yeah, yes, that's right. And I was thinking about this. Like, I think part of the frustration from clinicians specifically, which then bleeds into the patients themselves in terms of taking care of patients who are on medications for opioid use disorder, is I think that there is, especially if you've been doing this for a while, this mental model that opioids are like last line. You know what I mean? Like you've done everything else you can think of. Now you're on the final. It's the final boss of treatments. And if that doesn't work, then God, what are we going to do? And as a result, it's easy to kind of be like, well, we're already doing everything that we can, and like sort of throwing up your hands in dismay and not recognizing there's lots of other stuff that actually probably has better evidence than chronic opioids for chronic pain, like
Yeah.
including NSAIDs for a fair amount of patients. So we use buprenorphine, we use methadone for opioid use disorder, and then for patients who have opioid use disorder and chronic pain, hopefully treating both. But the evidence for them is not terribly strong, like you said. And
Yeah.
the evidence for opioids for chronic pain in general is also not super great.
Yeah. And when I would talk to patients about this, and when I would teach about chronic pain, I would always just say like, okay, medications, we're going to talk about that, but if we're talking about like what are our tools to fix your pain, it's going to be a lot of stuff like there's patient education. We need to get you sleeping, because if you're not sleeping, your pain's going to be worse. We need to address any stress or mood disorder or anxiety that you're having, because if your mind is not happy, the pain is going to be exacerbated. And then we need to fix your lifestyle, because like we talked about this on our osteoarthritis, we were talking about osteoarthritis on the last episode, but like if you are not eating the right things, if you're not moving your body is going to hurt. Like think about it, like when you're traveling, you're sitting in a car or on a plane for hours and hours, and then you get up to move, you feel terrible. Like you have to move. And that's just part of it. So I talk to people about those things, and then I say, and then medications can support this, but that's not going to be the one thing that's going to fix it. And when we look at chronic pain treatments, Paul, the effect size on a visual analog scale is like less than 2 points for if you're talking about a chronic medication therapy. So like if someone's at an 8, you're going to get them down less than, like, maybe to a 6 if you're lucky with a chronic pain medicine. It's not going to take it to a 2. You need all these other things that I just mentioned. So that's been my framing of this for years and years at this point.
I love it. And I will say, and I know this is only tangentially related to sort of patients or medications for opioid use disorder specifically, but I also think sometimes if we're not careful, the way that we frame discussions around prescribing opioids for pain is this thing that we like. Let me know if this resonates with you or not, Matt, but this idea that you have to kind of jump through these hoops before I'll prescribe the stuff that really works for you. You know what I mean? Like I often hear it framed as do PT first, and then we can maybe talk about oxycodone for your pain, which is not, it's not the right framing. And sort of, again, saving it as like the final boss of, effective management is actually not correct. And I think also setting you up for failure. And I think just sort of approaching it from the multimodal model that you're talking about is going to be much, much more effective. So I love that framing.
Yeah, probably. I think like the whole medical system almost like conditions doctors and patients to think that way, because it's like, oh, well, before we're going to replace your knee, we want to see you have done physical therapy, and if they tried an injection, and if you try, like all that stuff, and if you lost a little bit of weight, and then if those things don't work, then we'll pay for the knee surgery. I think people think that's what we're like, but it's actually, in this case with opioids, that's not the case. It's just they don't work, and they should not be, they should not be used chronically, because people develop a tolerance. People also will start to develop a physical dependence, and they'll withdraw when they're not taking the opioids. So they end up in this terrible situation where the opioid's not treating their pain, but if they don't take it, they feel sick. And I think there's so many people in that situation, and it's really hard for them to even know if that's the case or not. They just know they feel worse if they don't get their opioid. So,
yeah, no, that's exactly right.